With regards to the neoadjuvant studies that were presented at ASCO, it's exciting to see this data be presented and really think about how can we shift the paradigm for patients with localized disease. The majority of prostate cancer patients present with localized disease, but of those individuals, about 15% of patients have high-risk disease. And we know when we look at prostate cancer, specific mortality for those patients can be upwards of 40% at 15 or 20 years out from initial diagnosis. And the paradigm really hasn't shifted for how we treat these patients. It's either surgery followed by radiation and hormones or upfront radiation and hormones, and we really haven't shifted that paradigm. We've had a slew of studies that have looked at duration of hormone therapy in the context of radiation given or hormones given with radiation, but we haven't really shifted our paradigm. In the early 1990s, there was a series of neoadjuvant studies that were conducted that looked at LHRH agonists or antagonists, with or without anti-androgens, and these were largely surgical studies that looked at positive surgical margin rate, downstaging, and they didn't really look at pathologic complete responses. Patients weren't followed for a long period of time, the concept, the paradigm kind of fell by the wayside after a series of these studies that were conducted. But with the advent of more potent hormonal agents, abiraterone, enzalutamide, apalutamide for people with metastatic disease, it really presented an opportunity to investigate these agents in the neoadjuvant space. And we've conducted a series of neoadjuvant trials looking at various iterations and combinations of these therapies. One of the trials that was presented at ASCO looked at the combination of abiraterone and apalutamide versus abiraterone alone, given for 6 months in the neoadjuvant space. And I think, the big take-home message is that there is a subset of patients, probably on the order of around 20% of patients, that seem to have dramatic responses with neoadjuvant hormonal therapy. Either a past CR or minimal residual disease, which was defined as less than 5 millimeters of tumor in the remaining radical prostatectomy specimen. They seem to do, or it seems to be associated with a good pathologic response. Now, whether that pathologic response translates with long-term durable, remission, I think we need additional data to determine that. We actually conducted a retrospective pooled analysis of all of our prior neoadjuvant studies and demonstrated that for patients who actually had a pathologic response or minimal residual disease, no patient in the meta-analysis actually had recurred. That was with a 3-year follow-up time frame, and median time to testosterone recovery in that cohort was around 4 months. So, these studies really kind of paved the way for a very large phase 3 that's currently enrolling patients called the Proteus trial. The trial is looking at LHRH agonists with or without apalutamide. It's a randomized placebo-controlled trial, international study. Patients will get 6 months of neoadjuvant therapy followed by 6 months of adjuvant therapy, and then will be followed for a dual primary endpoint of metastasis-free survival and also pathologic response. So I think this is exciting and really just a lot of work being done in this space, largely led by Dr. Mary Ellen Taplin at the Dana-Farber